Hi, my name is Celine Tran, and I'm a second-year medical student at the Idaho College of Osteopathic Medicine. On today's episode of Do or Do Not, we have the privilege of interviewing Dr. Robert Cain. Behind the scenes, Dr. Cain is a true champion of osteopathy, serving as the president and CEO of the American Association of Colleges of Osteopathic Medicine, or AACOM. In his own words, Dr. Cain describes AACOM as a winding staircase which is involved in every step of the osteopathic journey, from the application process to medical school and into practice. Dr. Cain is a board-certified internist and pulmonologist who graduated from Ohio University Heritage College of Osteopathic Medicine. Before he became involved in AACOM, he served as Director of Medical Education at Grandview Hospital in Dayton, Ohio, and subsequently as the Associate Dean for Clinical Education at the Ohio Com. Over the past 2 decades, Dr. Cain has served on a number of local, state, and national committees, task force, and boards in a variety of roles, including the American Osteopathic Association and the first chair of the Accreditation Council for Graduate Medical Education Osteopathic Principles Committee. Dr. Cain's insight into the functions of AACOM, the AC-GME merger, the importance of osteopathic principles in residency, and the role of integrating OMM into pulmonary practice are truly enlightening. We hope you enjoy this interview.
Dr. Cain, thank you so much for being with us tonight.
Well, thank you. It's my pleasure.
Would you mind if I called you Bob for the time of the interview?
That will be fine.
All right, Bob. We're really excited to have you. And I always tell the students when they do their interviews, the idea behind our podcast is we want to hear about the journey of DOs and their whole physician journey. But specifically, there's always sort of a theme. So we invited you, obviously, because you're a great doctor, but also because you're president and CEO of AACOM. So can you start by telling us a little bit about the organization?
I'd be happy to. So AACOM, we should probably start with what that stands for. So it's the American Association of Colleges of Osteopathic Medicine. And we are nearing our 125th anniversary as an organization. And so we were founded in 1898. And our role at that time was to support the developing and growing number of osteopathic medical schools in the United States. And 125 years later, that remains our role. So we try to be the voice for osteopathic medical education. We serve as advocates for the colleges, and we support them in a variety of different aspects of medical education, research support, leadership development, faculty development, and so forth.
So I would imagine 125 years ago, there were only a few osteopathic schools, and now there's a lot. So, and has it grown over the years?
Well, it's actually a great question because I've been speaking recently with our communications department when I realized we were nearing our 125th anniversary. And I said, I'd really love to have some of those early records to know about the founders of AACOM, to understand what challenges they faced and the things they were thinking when they first came together. But my understanding is at that point, obviously, you could fit the deans of the schools around a small table and they could be able to function in a very different way. Today, with 38 fully accredited colleges and each dean is a member of the board, as well as others who are voices on the board, we have a pretty large room when we gather together. But again, a growing organization, and that's something we're proud of.
So Bob, just again, I really want to understand the organization a little better. And our audience are pre-medical students, medical students, and residents. So can you go through sort of how AACOM would interact or be important to each of those groups? So specifically, I guess my first question is, I know the application for DO schools is sort of a universal application through AACOMAS. Is that right?
Correct, through AACOMAS. Mm-hmm.
And is AACOM overseeing AACOMAS? Is that how the application process works?
Well, AACOMAS is one of our services for the member colleges. And so perhaps one way to think of this is I want you to think about a spiraling staircase. And so if you can put that image in your mind, that's part of the way we describe our Choose DO initiative. And so Choose DO begins with applying to a DO school. learning in a DO school, matching into a residency, certifying in terms of your board certification, teaching and practicing, so entering into practice, becoming a teacher, and then leading and promoting. And so think of it as different stages of your career development. And so AACOM really has some type of either product or program or service that's associated with each one of those steps on that spiral staircase. So if you're a college student or a non-traditional student who's looking to go to an osteopathic medical school, indeed the doorway into osteopathic medicine begins through the application process that is housed at AACOM. But then we have a variety of other ways to support the students through that particular journey, and the comms, each of our colleges who want to be able to track the data on the number of applications and the number of designations to the different schools. We have programs to help support the transition from medical school into residency. So match is a really stressful time for students, and a lot of background work goes on that most of the time they don't really realize is happening. That's occurring both on the side of the colleges as well as on the side of AACOM to support that process and try to make it successful for our students. As they move into practice, we have a number of faculty development programs and other ways we can engage the physicians so they become the teachers, the doctors of tomorrow. And then we have a leadership development program, which is actually trying to build education leaders who can step up and be able to take roles in each of our schools.
It sounds like a lot of work. That sounds like a big encompassing role. I mean, that's amazing. Can you talk a little bit more about that Choose DO program? So I've looked at that online. I think it's interesting that specifically from a student perspective, and obviously you mentioned there are other perspectives, but if someone's a pre-medical student, finding out what makes DOs different and what osteopathy offers, it seems like Choose DO is really doing a great job at doing that. Can you tell me a little bit about that initiative, how it started and what it's meant to do?
I can, and I'll tell you how it started and then how it's evolved, because I think that's what's actually important to the concept of Choose DO. Initially, the idea was that we wanted to be able to increase the number of applications to our medical schools. And so we want each of our schools to have a nice portfolio of students that have applied so that they can make strong selections, that they can put the right people into the seats of the medical schools. And so the idea was, how can we make the DO degree and osteopathic medicine more known to students that are in college and to non-traditional students who may want to enter into medicine? So oftentimes we were discovering that the pathway to a DO degree was an alternate pathway instead of a first choice. And so we think if you look at the degree and you look at the type of training and you look at the type of services that DOs offer, people should be made aware of it so that it could be a first choice in terms of entering into this particular pathway. So a lot of work went into that first step on that spiral staircase over the past year to really think through how can we begin to engage the applicant community in a different way. You know, linking to the advisors, the healthcare advisors, linking to others who can serve as role models for interest, people who say, I think I want to be a doctor. And later, I'm sure you'll get to the question, how did I, end up in osteopathic medicine? I'd like to think more people hear what I heard, which is, let me tell you about osteopathic medicine that influenced me and ultimately put me in the seat that I'm in today. And so when I first stepped into this new role a little over a year ago, as CEO, I discovered Choose DO, but it was only that first step. And when I reviewed all of the documents that the communications team and others had worked on at AACOM, I suddenly realized that we could build that whole staircase, because what we're really talking about is students making choices at every one of those points. The idea being that I've decided to enter into a DO school. Now am I going to choose this mindset? Am I going to commit to understanding osteopathic philosophy, thinking about osteopathic principles and how they can be applied to make sure my patient gets the kind of care I want them to receive or I want to receive as a patient? When I move into residency, do I want to continue graduate level education in osteopathic principles and practice? Or am I okay with what I've learned in medical school? As I certify, do I want to continue that momentum in a way that hopefully allows us to better serve you through your career? It's not saying one is better than the other. It's saying we think we can serve the students better who pass down the AOA certification pathway. It's the idea, and we could get into a whole conversation about this, that sort of Dell computer versus Apple computer. You can innovate and move faster in terms of change when everything is under one umbrella. So we're trying to find a pathway that does that for you, for our students, so that we can hopefully have a nice, positive career experience for you. Each step after that, you choose to teach, and you begin as a good role model to share those same things that brought you in through the door, and eventually you're a leader and promoter in a way that advances osteopathic medicine for the next generation.
That's great, Bob. And we're definitely going to get to your story, but I have a few more questions. One of the things that you alluded to, that there are a lot of questions to the medical student going into residency, is that when you and I applied for residency, obviously there were osteopathic residencies and allopathic residencies. And one of the interesting things, I think, in the past about being a DO is that you were sort of a free agent, I always said. You know, you could do an osteopathic residency, you could do an allopathic residency. You had a lot of pathways open. And over the past few years, so now there is only ACGME residencies. So they're both merged. Can you talk to us a little bit about that?
Absolutely. You know, this was a huge decision on the part of AOA leaders and ACGME leaders in terms of working to bring together the two systems. And I think it's easy to see why in the beginning there were so many concerns one way or the other as to what would it mean for our students and what would it mean for the profession. So I think there's two things that I would probably share with you that we have to keep in mind. So success and concerns about students, you know, what would it mean for the students? This year, at the end of the formation of the single system, our match success rate was, by the time final placement was done, was 99.29%. No different than any of the past several years, despite the fact we were looking at one system for graduate medical education and one match. So I think that we have a lot of fears that we get worked up about. And an important thing to keep in mind is that our students are highly desirable by the graduate medical education programs and by the medical community. I'm so privileged to hear so many positive comments about our students. We have to keep that in mind, that those fears haven't really played out. Now, we have to continue to be vigilant. That's why I mentioned those groups that are working all the time to try to figure out how do we maintain that kind of a match rate. So one important piece. The other point is, and in part the reason I know this is because of the honor I had to be the first chair of the Osteopathic Principals Committee, which was the group at ACGME that was charged with creating the footprint of osteopathic medicine inside of ACGME. So to create the Osteopathic Recognition Program. I had the opportunity to attend Council of Review Committee chair meetings, which was all the review committee chairs coming together. I had the honor to be present at board meetings and to work with various leadership groups. And what I've seen as a result of that and traveling across the country for the Osteopathic Principals Committee is that more people in more places are talking about osteopathic medicine than ever before. And it's not us having to start the conversation. And in most cases, there are one of two things you'll see. Either it's an inquisitiveness that they want to know more, which gives us the chance to tell our story, or they're actually asking, why didn't I learn medicine from this perspective? Why didn't I learn these skills? And in fact, we have examples of LCME schools that actually created pathways so that their students could learn enough basic principles of osteopathic medicine to be eligible for those residencies that have osteopathic recognition. So my perspective has been very positive, but it is like anything else. It's what we make of it, right? We have to be willing to go in and take advantage of what it is that's been put into our hands and build on it as a profession.
Just so I can be clear on this, if an MD decided that they wanted to apply, there are specific residencies. You need to have a certain amount of osteopathic hours for those residencies. An MD can fulfill those osteopathic requirements and apply for those residency programs. Is that the way it works?
There are ACGME programs that have chosen to take on additional work in order to integrate an osteopathic curriculum into their graduate medical education program. So we're both internists. I think you're a gastroenterologist,
Yes,
correct?
correct.
Oh,
Correct.
okay. So I'm a pulmonologist, you're a gastroenterologist. So both the general medicine program and the fellowships can apply once they become ACGME accredited. So they have to go through the entire accreditation process. Then they go through an extra step to become recognized, to actually be able to add the designation of osteopathic recognition. Once they have that, two things happen. A DO who says, I want to continue my education at a graduate level. I want to further develop these principles. I want to develop further my manual skills, that they can take that pathway. But it also opened the door for MD students, so new graduates from an MD school, to potentially enter down that same pathway. And so the programs do have to work to make sure they're able to incorporate that, something equivalent to that 200, 250 hours that you and I had in the DO school, into residency, and bring people up to speed, because they're subject to the same milestones as DO graduates, and they have to move through the program and complete the same expectations.
I think that's super interesting. So you're on this committee that's specifically addressing osteopathic principles and practice. Does that committee set up guidelines for what needs to be included in the residency, or just how the process works? Because that committee seems so key to keeping osteopathy in graduate education. What specifically does that committee address?
Sure, I can walk through that. Now, I actually left the committee when I took this role. I could not be on the committee and serve in my current role, but I had several years serving as the chair, 3 years as chair, and then an additional year on the committee as past chair. The first thing we had to do was to actually set up, in a very short period of time, requirements for operating osteopathic recognition. So just like if you go to the ACGME website tonight, you would be able to find the requirements necessary to open a program in internal medicine, as an example. So the program has to meet all of those requirements. We were expected to set up a set of requirements exactly like you would see for a program, but they guided the program in how to integrate osteopathic graduate level education into their residency program. And so it's on the program to go through that application process and to assure that indeed that has been done. We're very clear in the way the requirements were written. It's not an add-on. It's not internal medicine plus this. It's internal medicine with the integrated osteopathic principles and practice. The program took nearly a year to fully develop the requirements and all of the footprint and the thing that we needed to have in place before we took our first program. So a lot of work in that particular process. Today, I think as of the last committee meeting, if I remember, there are 245 programs across the country that have osteopathic recognition. A really important point, which I think speaks to this idea of the change that's occurring. Consistently about 15% of programs that apply for osteopathic recognition had no historical ties to osteopathic medicine. So they are historic ACGME programs, what in the past we would have called allopathic, that have said we want to add this to our programs. Now, most of those, as you would not be surprised, are family medicine and internal medicine. But I think it's exciting to watch that interest present in our part of the House of Medicine.
That's great. It's sort of an offshoot question. I was trying to do a little research. I was looking around online, preparing a little bit for the interview with you. And I was on the MD application site, which is the AAMC. Interestingly, on their website, they have a section that shows the difference between a DO and an MD degree, in a very nice way outlines the two degrees. Do you think that is part of this whole process?
I find working with the AAMC in my 1 year of experience to be a positive thing. We interact with each other as complementers in the healthcare system, which is exciting to me because one of the principles I believe in is called co-opetition. And the idea that can we identify in particular entities that complement us in a way that together we do more. And if you and I think about the complexity of the healthcare system, all the sectors and segments that exist, whether it be the academic health research centers on one end or the small community hospitals and teaching health centers on the other end. And that's not one is better, one is worse. That's just a huge spectrum of difference. The needs of patients in between, rural versus urban settings, small institutions versus large institutions. It's a little hard to imagine that any one entity can commit to all of those. And part of what we bring to this system is a greater understanding of that community-based system of education and care. That's where our engagement has been historically. It's where our AOA GME programs existed for the most part. That's a core competency for us. And our ability to connect with AAMC, there are things only they can do, there are things only we should probably be doing, and there's an overlap in the middle. And together we can do more. And so I'm not surprised that that would be on their website, because I think we're just a simple recognition that there are 2 degrees and that there are different pathways to medical practice in the United States.
All right, Bob, this whole discussion has been awesome, and I understand a million times more than I did before we started, and I thank you for that. We're going to kind of shift gears a little bit and go into our regular episode and focus on you a little bit. And we're just going to talk about you, which I'm super interested in also. We start every episode by just asking, can you tell us what your day looks like? When you wake up in the morning till you get home from work and or ready to go to bed, what do you do? What does the president and CEO of AACOM do on a normal day?
Sure. Well, pre-pandemic versus post-pandemic are totally different. Pre-pandemic, I was on the road a lot, and at least a third of my time in the first year, I was someplace other than home or the office. And so as president, that's my external facing role to engage the community, both our osteopathic community and the many other professions that make up the healthcare system. And so there's a lot of external work that actually goes on. In my role as CEO, that's actually making sure the operations of AACOM are effective and able to support everything that we've been talking about. So I would spend a portion of my time, obviously, in the office and trying to work with my leadership team and the rest of the AACOM team to deliver on those. So working on the strategic plan and the operational effectiveness of AACOM. There were long days, there were a lot of hours, but they were more predictable then. I think the idea that it was probably about 8 to 10 hours of meetings and engagement, and then in the evening reading and other work that had to be done, emails and things that would typically occur. It wasn't much different than being in pulmonary practice, to be honest with you from that standpoint. Typically weekend work, the hours, 3-4 hours a day on the weekend of review, and then whatever reading I want to do just for my own development. Post-pandemic has been very different. So today has become more like the typical day. I started at 4 a.m. and worked until 7 doing emails and writing that I needed to do. Started my first meeting at 8:30 and ended at 5:10. Got in a very quick workout for an hour before coming back to have my time with you. And then I still have today's emails to do after we're done.
It's amazing. It seems like a lot of my friends in finance and law, people working from home feel like they're putting in more hours post-COVID than pre-COVID. You think that's true?
Yeah, it's sort of every day is the same thing. So instead of having travel on one day and office another day and a little bit of downtime, every day is the same day. And we've just progressively lengthened our days to fill the many requests from many people. But you know what? It does lead to things like this, which happens to be very exciting.
So Bob, we're going to go back, if you don't mind. Tell us where you grew up and where you went to college.
Sure. So I grew up in East Liverpool, Ohio, which is a town on the Ohio River, right near the West Virginia, Pennsylvania, Ohio border. My father was a pharmacist, and while I can't say that alone caused me to enter medicine, I will say finding his college chemistry and science books when I was a young kid probably had some effect on me. But I was active with sports and band and just enjoying the outdoors as a kid. I ended up going to Westminster College in New Wilmington, Pennsylvania. And it was actually there that I knew I went to Westminster knowing I wanted to be a physician. So that decision was probably made in high school. Good role models. And again, my parents supporting that. But it was actually at Westminster where I made the decision to go into osteopathic medicine specifically and did not pursue an MD degree. And that pursuit ultimately led to medical school at Ohio University in Athens, Ohio.
Now, Bob, do you remember exactly when you learned about osteopathic medicine or what drew you to osteopathic medicine? What made you ultimately want to go to Ohio?
Yeah, well, actually, it's an amazing story in my mind why I entered osteopathic medicine. It's why I always encourage role models to be the ones telling our story, because the person you're talking to may be the next Bob that decides they want osteopathic medicine because of that story. So I had decided to train to become an EMT when I was in college. I thought, what a great way to sort of be engaged with medicine and a great way to do something valuable. And I was working part-time while in college with an ambulance service in Sharon, Pennsylvania. And Sharon, Pennsylvania had two hospitals at the time. One was called Shenango Valley. It was an osteopathic hospital. And the other was Sharon General. And when I would go in to each of those emergency rooms on runs with the ambulance service, well, of course, I wanted to say I'm a pre-med student down at Westminster because everybody knew Westminster. And I thought, I'm in the hospital. What a great place to say you're a pre-med student and get to talk to doctors. Here was the difference. It didn't take a fraction of a second for the physicians working in Shenango Valley to say, oh, you want to be a doctor? Do you know anything about osteopathic medicine? And to start telling their story. And you and I both know stories affect human beings, right? The best way to get to someone is to tell a story. And they would tell their story about why they entered osteopathic medicine, why they were proud about osteopathic medicine, why I should consider osteopathic medicine. When I went to the other emergency room, I was lucky to get their attention. So I started becoming attracted to this group of physicians who then, as they got to know me, would you like to come to our office and be able to observe? Pre-HIPAA days, very different then, but to be able to go watch that. And eventually, one of them came down to the college to do a presentation about getting into osteopathic medical school and doing osteopathic medicine. My choice was solidified. I didn't even have to look back. I knew that's what I wanted. And I wanted it because I was attracted to the philosophy, because I was attracted to the idea of using my hands in terms of OMT, and I could be a physician. Whether I went a medical pathway or a surgical pathway, I'd have all the privileges that an MD would have. So it was the right choice for me. So probably no surprise that I'm so into the idea of Choose DO and creating that pathway that's laid out clear for students to understand what they could be part of if they enter into osteopathic medicine.
I think the story is amazing. I think mentors are huge. And, I think we've shown in our podcast again and again, sometimes you just meet a doctor that's passionate about what they do, and that kind of sets you on your journey. And I think it's so important for people to hear the osteopathic journey because I think it's so profound. And I think people are so moved and changed by their experience through osteopathic school and with osteopathic doctors, just as you were. So you have this passion, you decide this is what you want to do, no questions. You started osteopathic school, and can you tell me about your experience at school and how you decided that you wanted to be an internal medicine doctor?
I loved being in Athens. We were much smaller then, just 100 students. I think our actual count was 105. If I recall. So a very intimate class. I'm pretty sure that if you were to ask my classmates in medical school, so here comes the brutal honesty, who is the least likely person ever to be leading the American Association of Colleges of Osteopathic Medicine, they would have voted for me. I was the quiet guy that, probably didn't get noticed a whole lot in terms of being a medical student. But I made the right choice, and I loved being part of Ohio University. I went to Sandusky. So the first 2 years were in Athens for our basic science courses. And then I went to Sandusky to a small community hospital there where I was a third and fourth year student. I ultimately stayed there and did my traditional internship in Sandusky, which was an awesome experience because the only other house staff were two family medicine residents who were mostly in the clinic. So we had one-on-one time with the physicians on every rotation. So whether it was surgery, internal medicine, or obstetrics or emergency medicine. So it was a great experience. I actually went to medical school wanting to be a pediatrician. And for reasons that would take far too long to describe, ended up making the decision that wasn't for me. And right about the same time, had a physician I was working with in Sandusky, Anthony Linz. Dr. Linz was also a pulmonologist, and he was a great role model. And so he talked to me about where he had done internal medicine and as a residency, and talked to me about pulmonary medicine, and started building my interest in pulmonary medicine. So I ultimately arranged for an interview with the internal medicine program at what was then Grandview Hospital in Cleveland, Ohio, and went there, did my 3 years of internal medicine, continued to see growing interest in pulmonary during that time, and someone recommended Grandview Hospital in Dayton, Ohio, where Don Burns was the program director, a well-known pulmonologist in the profession, one of the first in the osteopathic profession. I went there for the fellowship and been moving forward ever since. But that was sort of my pathway to practice.
Thank you for sharing the story. But going back to your theme, it seems to me like you found role models to kind of steer you towards osteopathic medicine. And then in the same way, you found a role model that sort of put you on your path to pulmonary because of his passion. Again, I think that one-on-one, you think maybe you want to do something, and then you meet someone who you just look up to and is a good person and a good doctor, and you just say, I want to be like them.
Yes. Well, I tell people very openly, Dr. Linz was one of a handful of people who changed my life, changed my career, along with Dr. Burns.
You did your pulmonary fellowship. You're very involved in osteopathic manipulation. This always comes up. Things like pedal pump and rib raising. Did you find those things useful in your fellowship? Do you use those things in pulmonary practice?
So the sad part was that until about 2002, because of those things not being integrated well into my residency and my fellowship, there was this distancing that occurred. I never lost interest. That's why I went to a DO school, remember? So I'm attracted to philosophy. I'm attracted to the use of my hands, but it wasn't integrated into the programs the way it needed to be. And that's the good part about osteopathic recognition. You have to integrate it if you want to maintain that status with the ACGME, right? So it's going to be a heavy expectation on those programs. So I finish up my fellowship and I head into practice, and I realize I am treating patients differently. I'm engaging with patients differently in terms of well beyond just the problem that they're there for. Am I really understanding their family life? Am I really understanding the things that are potentially affecting their functional status as, let's say, a COPD patient? But I wasn't using any OMT initially in my practice. So in 2002, once again, here comes this role model theme. I was presenting on a topic called proactive health management to the Kentucky Osteopathic Medical Association. And a very excited gentleman came up to me during a break. His name was Ed Stiles. And Ed changed my life because he sat down with me, wanted to have lunch, and he wanted to talk about how my proactive health management approach for pulmonary disease integrated with the use of OMT and how those two things should go together to help patients find their optimal health status, their optimum health potential. So Ed, whom I so appreciate for what he did, not only started sending me his pre-doc OMM fellows with the Pikeville School. So I had these students every few months who were coming in, and they were teaching me, helping me relearn how to do OMT. But Ed himself came to my practice and spent days with me, retraining me to integrate that into my patient care. And once I made the connection again, that if you really think about the musculoskeletal structure of the thorax, it lends itself incredibly well to exactly what osteopathic medicine is about from a structure function standpoint. And the idea that structural health, structure that's operating the way it should be effectively, function follows. And so patients with COPD, there's significant derangements that you can identify? Patients who are on the ventilator, that have increased work of breathing. Can we look for things that can help us potentially reduce their work of breathing and to not only have an improvement in their symptoms, but improve their functional state? And so it was exciting because that was a changing moment in my career, that after that, I worked that much harder to examine my patients from a structural standpoint and to integrate that into the care, both in the office and in the hospital.
That is just super. Just to go back a little bit, when you graduated your fellowship, how did you choose that first job?
Well, in some ways it was chosen for me. I left for Dayton for the fellowship with the plan that I would return to Brentwood in Cleveland. And they had asked me to do so after I finished the fellowship. So I was excited about that. I enjoyed the team of physicians at Brentwood and was looking forward to returning to that area. It was much closer to my family in Eastern Ohio. But during my 2 years in Dayton, it changed ownership. So there was no way to go back. And the new owners weren't really interested in a private practice physician joining Brentwood Hospital. So I was left, this was 6 months before I was going to be done with my fellowship, and I was left with, now what do I do? And where do I go? And this is something I've always been so amazed by, and it speaks so much about him. But the program director, who was my mentor, again, Don Burns, that I mentioned before, sat down with me one night and said, I think I'm ready to start to cut back and maybe just run the pulmonary function lab and not see patients anymore. I'd be willing to give you my practice to stay here and join the medical staff in Dayton. And so he did just that. He gave me his patients, and we started my practice essentially from scratch as a business, but I had a ready-made source of patients and moved forward from there to stay in Dayton and become part of that community, which set in motion many of the other things that lead to today.
So you're in a pulmonary practice, you're in private practice. At what point did you start getting involved in organized medicine? And then ultimately, when did you take the plunge to go full-time into organized medicine?
So I started teaching relatively quickly with the internal medicine residency that was at Grandview Hospital in Dayton. By 1999, so about 5 years after I finished my fellowship, I became the internal medicine program director. And I continued in that role through actually 2007. So for that period of time was program director. I became engaged much more deeply with academic medicine beginning about 2001. And that was partly because of the Centers for Osteopathic Research and Education, or CORE, and activities that were associated with it. Over 4 years, I guess, was doing the right thing, that the hospital president at the time wanted to have a new director of medical education and approached me and asked if I would take on not just the internal medicine program, but was I willing to be the director of medical education for the facility. So for a period of time, I was trying to be the internal medicine program director, the director of medical education, and run my practice. And at some point, my wife said, you're losing your hair. And
worse things than that, Bob. Worse things than that.
Maybe you should think about that. But the thing that caused me to finally leave practice was in about the period 2007, 2008. I mentioned this proactive health management approach. We prided ourselves in our practice of wanting to prevent hospitalizations, getting patients into the office, getting them seen as quickly as we possibly could to avoid emergency room visits and avoid hospitalizations. And that was a source of pride for me and for my whole team. And as I found myself more and more saying, go to the emergency room, go to the emergency room, go to the emergency room, I started realizing the patients weren't getting the attention that I felt they needed. And so I started backing away. First, it was doing less critical care. Then it was backing away from the office and finally saying, I can't do this alone. And so we had to spend time finding homes for all of our patients and closing down the practice and then moving full time into academic medicine as the director of medical education, which I continued in through 2014.
And then at what point did you decide you wanted to take another step and become president and CEO of AACOM? How did that happen? Did we talk to Karen Nichols, and we had a great interview with her, and she made it sound like somebody just called her up on the phone one day and said, Karen, you're not doing anything. Do you want to be dean of a medical school, or do you want to run a committee on the ACGME? So did somebody just call you on the phone and say, hey, Bob, what do you think about being president or CEO, or how did that come about?
Yes, that's exactly what happened. So I was working for Ohio University, and I was the associate dean for clinical education. It's such an amazing feeling to go back to the school I had attended, and now to be one of the leaders in that school. So I love my role. I love the team that I had the chance to work with, and I wasn't really looking for any new role. In my role, I had the opportunity to engage with all of the hospitals where our students were training, to address that relationship, to address the educational program for the third and fourth years. And so it was, from my standpoint, I thought the job I would simply continue with for quite some time. And then I happened to be at a ACOI, American College of Osteopathic Internists conference in Florida. And one of my colleagues came up to me and she said, I have a question for you. And she said, Steve Shannon, who was the prior CEO, is stepping down. You might know that from AACOM. And I've been asked to find out if you might have any interest in the role. And I said, well, I haven't really thought about it. I'm happy where I'm at. She's like, well, I think you ought to consider that. So I had a conversation with my wife about, what that would mean, because we would have to move and there'd be some significant lifestyle changes. I traveled a lot with my old role, but it was definitely going to go up if anything happened. And I really didn't ever imagine it would play out that I would be in this role today. And through each of the multiple steps, I finally applied sort of at the last minute, and going through the interview process, each step, I would say, oh, no, they're never going to take me to the next step. And my wife was like, next year we're going to be living in Washington, D.C., don't you? At least she had faith in me, I guess, or believed in me. But indeed, we kept moving forward. And all of a sudden, we were down to the final step. And the offer was made to be the next president and CEO of AACOM. And again, I never imagined being here when I started so many years ago in Westminster or at Ohio University, but it's an amazing privilege and honor.
That's a great story. Yeah, that's beautiful. Bit of a personal question, but obviously this is some journey starting as medicine, and you ran a program, and then you're doing academics, and now you're uprooting your family and moving them to Washington to take this position. Was that difficult? How was that?
Well, she's an amazing supporter. So without her, I wouldn't be here. I have to say that. But we didn't actually meet until 2003. So from a standpoint of family, we don't have any children. And families, she was from the Dayton area, so they are all there. But she's been incredibly willing to make these shifts and try to make sure we take care of getting her back there as often as we can. Definitely my supporter. It was tough for both of us. I'd never lived outside of college, outside of Ohio, and even that was just to go to college and go home. So 57 years, and all of a sudden moving here to Maryland. It's been a good experience.
But she's still been supportive of the move, and it sounds like everything's great, and you're smiling, and it sounds like you're having a good time in Washington.
Absolutely.
Bob, again, thank you so much for your time, first of all. I have a little bit of an unrelated question for an osteopathic pulmonologist. So we interviewed the curator of the A.T. Still Museum in Kirksville, Missouri. And I just find it so interesting talking to different people about osteopathic medicine. And this is not a physician. He has an honorary DO, very nice man. But one of his points, which I thought was a little bit profound, and I'm curious what you think about it, is that many people that are not in the osteopathic profession maybe don't appreciate the structure and function connection in medicine. And one of his points was that in the setting of COVID, many people know, I think some people listening will know, maybe don't know, but prone ventilation during the peak of the pandemic was such a big deal, which for a pulmonologist, I don't think is anything that profound. Like this was known treating ARDS patients in the past, but using it as sort of a bigger picture to say, listen, it's easy to say that drugs and surgeries are important, but actual structure and function makes sense. So he made a big point of the fact that we take prone ventilation so easily as a normal concept, but maybe other structure and function relationships take a little more time to understand for a non-osteopath. Do you agree with that? I mean, what do you think of that whole line of thinking?
I think I understand where he's going and what you're asking. And it is sort of a question I face with MD colleagues who say, well, help me understand what it is that you're talking about. And so I usually try to simplify the image of what structure function means. And so what happens with a COPD patient in acute exacerbation that creates their symptoms? Ultimately, they have to have an increased work of breathing to move through all the steps and stages that are associated with that exacerbation, whether it's because of airway edema or extra secretions or spasm that's occurring to move the same amount of air in and out. They have to work that much harder. If on top of that, you compound that work by now adding that the spine isn't moving into the right flexion and extension when required, the ribs aren't raising and lowering as you expect them to, so to elevate and depress in terms of inspiration, expiration, because of some kind of induced somatic dysfunction, you've now added more work of breathing to their problem. And so the way I would explain it to an MD colleague would be by going ahead and doing that examination of the thoracic cage and looking for anything that might contribute to additional work of breathing. Not only would I do the things to reduce secretions, reduce bronchospasm, reduce edema, but to try to remove that impediment created by the changes in the thoracic cage. And so that sense allows us to add that additional care. Another way to think of it is put on a rib vest, like they used to use when people have a fractured rib, and try and take a breath, right? You can't get your ribs to go up. Well, that's no different than rib dysfunction. And so that impediment that's created, we have a skill that you and I learned that can potentially try to reduce and change that dysfunction in a way that improves rib motion.
Yeah, Bob, that's exactly, I think, what he was trying to say. That's perfect. And I really appreciate that. And I hope that our listeners can really process all of that, because I think, again, pharmacology, surgery, as you said, and manual medicine all come together. And that's what makes the osteopath special, is that we have all of the quote unquote standard tools, and then we also have an extra tool added.
Now, if you think about COVID right now, though, just to link it to what I think you were asking in that question, if we have patients who are in some way experiencing shortness of breath, you want to understand what the source of that is from a work of breathing standpoint. Follow the same example. Now do the examination of the thoracic cage and look to make sure there's nothing else compounding it. So a misunderstanding I think people had would be to say, we're going to use OMT to treat COVID. No. What we're doing is using OMT to try to make sure that conditions exist so that as the patient's trying to recover from COVID, we don't have additional things that are limiting that recovery. It's a way of seeing the patient that's just different than I think is otherwise taught in medical school.
That's perfect, Bob. Thank you for clarifying. That's amazing. I have two final questions, kind of a grand finale questions. And I think it's so interesting. I'm a big fan of biographies and listening to people's stories. And as you said, as doctors, we're sort of listening to people's stories and telling stories. That's part of what we do. And I think what engages us with patients. I think it's interesting, just when you started, you said that you were kind of the quiet guy in your medical school class and you grew to be the president. Again, I'm very impressed with the interview and I appreciate your time, if I haven't said that 20 times already. But if I asked you what was your superpower, what really allowed you to get to where you are today, what would you say that is?
Well, it's something that I find harder and harder every day because of the amount of conversations happening and amount of engagement and materials. But it was listening. I wanted to be a deep listener who was really trying to understand. And the same thing with materials, especially in meetings and things that we had to do to really try to understand sort of the issue behind the issue. And I will say in this role, it's much harder when you start worrying about the executive summary to understand as deeply. So that's meant having to really pay that much more attention in terms of listening. So I would say it's listening.
My last question for you, can you give us one piece of advice, and it doesn't have to be one piece of advice, it can be more than one, but can you give us some advice that was given to you by a mentor of yours, whether it could be your parents or a teacher in high school, somebody in residency, or your fellowship director that was so instrumental in getting you to where you are, a piece of advice that was given to you that you think about regularly and you would like to pass on to the future doctors listening to the podcast that you think would help them along their journey?
May I use 2?
Absolutely. We'll take, if you have 5, we want wisdom. So we'll take as many as you have, but 2 would be great.
Well, the first comes from earlier in my life. So I developed an interest in Olympic weightlifting when I was in junior high school. And by high school, had managed to find in my hometown a retired Olympic weightlifter. He had been candidate for the 1968 Olympic team and ended up with an injury that kept him from participating. But I learned about him through a friend and reached out and asked if he would help teach me, would he help coach me to become a better lifter. And we'll only talk about rule number 3, but there were 3 rules that he had if he was going to help coach me. And the third one was, you will not try to win. And I can just remember this young high school kid, and the only thing I'm imagining is a gold medal in the Olympics, and that it was about getting to the gold medal. And he really, in his way of teaching, was able to show me that it's not about the end point, it's about the journey. And what he kept focusing on again and again and again was, I just need you tomorrow to be better than you were today. And so it was really a form of continuous improvement. We would think of it in medicine. And by doing that, rather than trying to reach for the win, as he would say, eventually someday, if you're better tomorrow than you were today, then the others will fall by the wayside and the win will come. And so your mindset is in the right place as you go through the process. So that was something that shapes the way I think today and how I want to run the organization and how I want to work with other people. The other happened as I was leaving from my internal medicine residency and headed to my fellowship. And so the assistant program director, Mark Pace, a cardiologist at Grandview Hospital, sat down with me, and he was just a really humble guy. And he said, I'm not a particularly bright cardiologist. I just do my job. I'm probably just average, which he was far better than, but he was never going to say that. And he said, what I want you to remember as you head for your fellowship is this: always start from the beginning and listen to the patient. And while he didn't talk about it in terms of diagnosis momentum, what he was really teaching me was the idea of diagnosis momentum, that too often we pick up on what's in the chart or what the last physician told us or what someone shared on the nursing staff or even the patient, and it guides and affects our thinking. Sit down, start with the patient from the beginning, get their story, and most of them are going to tell you what's wrong with them. And it's your job to listen and to ask the right questions and to get to the way that you can help them the most. So those 2 things have definitely shaped my career and my life.
That's great advice, Bob. Thank you so much for sharing everything about your journey. Your time is invaluable to us, and we really appreciate it.
Well, thank you so much.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there's someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea. Thank you guys so much for listening to Do or Do Not.